Okay, good morning, everyone. Welcome to Coffee and Cases. This morning we have chats just around some trauma stuff and some airway things. Just a few notes before we get started. A reminder just that you need to complete the register at the end of the presentation and not at the beginning of the presentation, because you are going to need the word of the day. It's also really important that you complete the register before 12 o'clock today. Otherwise, the points are not submitted. And please make sure that your HPCSA number is correct. Those who have submitted incorrect HPCSA numbers are not receiving the points. If you can't put your own number in correctly, it feels like maybe you shouldn't earn the points. So I'm really sorry about that. Just some other thoughts. We are creating a really safe space, so I'd love to hear your thoughts about the presentation that we're going to share today, and maybe some of your experiences with the airway stuff that we're going to chat about. Please don't feel shy to pop up your hand and just give us some your perspective. And then lastly, today we are sponsored by LenMed, which means that this presentation will be freely available after the fact on our YouTube channel. Please go and have a look at the channel, subscribe so that you don't miss anything. And I'd like to just give LenMed, Elena is online, just an opportunity to say a few words, Elena, if you want to.
Thank you, Caleb. Good morning, team, and thank you for this opportunity. So I'm Elena Govender. I'm the quality manager based at eThekwini Hospital and Heart Center. We have a facility in KZN, Durban. And I just want to give you a brief overview of the offerings at our facility. I promise I won't take too much time. So eThekwini Hospital is currently we're up to 456 beds. That's inclusive of a 41-bedded rehab facility, which is fairly new. We've just opened it this year, Jan, and started taking on cases. We currently are a center of excellence, and our group has a profound focus on clinical programs. So our facility is lucky enough to be involved in all of these clinical programs. Some of them are the American College of Cardiology accreditation that we have acquired. This was acquired in 2022 and is still maintained up to now. A strong focus on chest pain and PCI, a lot of stringent factors and components that we have to meet, especially door to cath lab times and door to PCI times. And thus far, we have actually achieved all of our timeframes with the ACC accreditation. Also, of late, we have a new certification on board, which is our transcatheter valve certification, or other words, it is our TAVI certification that we have. That was just acquired this year in Feb, so it's fairly new, stringent criteria as well, but we're still on the ball with that. A lot of factors in play. And we just want to advise our patients, even our doctors, this is a center of excellence. Patient safety, a patient-centric approach is something that we really value and we really trying to advocate for. And we also have stroke offerings. We are now a stroke center of excellence. We have affiliated with the Rescue Dashboard as well as Angels. We currently have a total of 11 WSO Angels Awards, 2 gold, 1 platinum, and now we have 8 consecutive diamond awards. So huge team focused. Everybody's on WhatsApp group. We monitor times at any given time. It could be a stroke at 2 a.m. in the morning. And the team are still very good. They still adhere to all of the time frames as well. And last but not least, just something that we wanted to advise you on, that we do have a transplant division on site as well. The transplant offerings are that of heart, lung, and kidney. And it is the only facility on KZN that can offer the left ventricular assist device implantations. So this left ventricular assist device is a bridge to heart transplant, especially for those candidates that can't find a suitable heart. It can also be used as destination therapy for those cases with severe heart failure and choose not to actually progress to a transplant. So those are some of the offerings that we have for here. We just want to advise you that we are a center of excellence. It's a great facility. We're based in KZN, Durban. You're more than welcome to pop in, visit us. We can actually take you to a walkabout through the facility. But we've actually are very great to have this opportunity to inform you about us. And if you want any more information, please feel free to reach out to myself. You can use the QR code from the Coffee and Cases link earlier this morning, or you can visit the lenme.co.za site for further information. Thank you, Caleb and team.
Thank you so much also for your engagement in the Coffee and Cases platform. It's amazing to have the support and to be able to provide these presentations free to pretty much anyone who wants to watch them. We're going to start out today just sort of chatting about a case. This case is a case that happened quite a long time ago, so it's not a very fresh or new case, which is a little different to usual. But the learning is still really relevant. It is one of the Coffee and Cases presentations that we actually presented in the very, very early days, probably sort of the first few months of Coffee and Cases. And for those who are relatively new to the platform, and definitely in our first few months, we really only had around 5 or 10 people join. So it's quite cool that we can now share a really cool case. I have just disabled mics for everybody at the moment, just from the perspective that we'll do the presentation and then open up mics a little bit later. If your hand is up right now, please feel free to put a question in the chat. But there is audio and pretty much everyone else can hear. So if you can't hear, then it might be you. Or maybe a signal issue. So the case that we're going to chat about super quickly is a case that I was dispatched to a very long time ago now for a gunshot face patient who was in a hotel kind of area and had attempted suicide. He'd kind of checked himself out of a psychiatric facility that morning, had gone home, fetched his weapon, and then checked himself into a hotel so that he could commit suicide in a place, I guess, that was more secluded. So quick hits of the case. Obviously, it was a gunshot face. The information that we had available to us at the time was a very short video clip, which showed a patient who was, for all intents and purposes, GCS 1515, but obviously he didn't have a tongue to speak or a face really to be able to figure out if his eyes were opening, but he was making meaningful movements. There was ILS crew on scene, and the patient was bleeding profusely. They had done everything that they obviously could, but because it was a massive facial wound, he was bleeding quite a lot from the airway, and this is sort of where the challenges started. So they had positioned him really nicely in an upward position. He was sitting upright. He was sort of maintaining what airway he had left. There was no ALS nearby, and so they were obviously quite concerned around pain management and his airway, but also the fact that he was bleeding so much from his airway that they weren't entirely sure that they were going to be able to stop the bleed without absolutely occluding his airway. Trauma center was quite far away. There were 2 or 3 relatively small facilities nearby, but the time to patient side from the HEMS environment was a lot quicker than what the drive to those little facilities was going to be. And the crew really, as they walked in the door, realized this was a patient that they definitely didn't have the abilities to manage. And so they activated HEMS probably within about 5 minutes of arriving on scene. So the time to patient was relatively quick. Initially, his GCS was relatively high. Again, it was difficult to kind of figure out what it was, but when asked for his ID book, the patient was able to reach to where it was, pick it up, and give it to the crews. He wasn't obviously able to communicate incredibly well, but he was making meaningful movement, and he was able to sort of do all the things that he needed to do to be able to show that his motor component was relatively high. He had a horribly threatened airway. And so one of the things that we noticed on that first video was just the sound of an absolute airway occlusion. He was working very hard to breathe. He was moving as much air as he possibly could. But this gaping hole in his face was part of his giant problem. He was bleeding out. And this is probably the thing that the crews were the most concerned about, was that he was literally just pouring blood from, I think, probably the base of skull fracture, but also just the open wound in the front of his face. And no amount of trying to stop the bleeding was stopping the bleeding. No amount of trying to stop the bleeding was allowing the patient to continue to oxygenate and ventilate. And so this was really, really challenging for the crew, but also for the patient. He had lost a large volume of blood on scene and was compensating for it. When we arrived to the patient, I remember stepping out of the helicopter, and the patient had been brought very close to where we landed at sort of a golf driving range. and he was in the back of the ambulance when I stepped into the back of the ambulance. And the picture and the video had definitely not prepared me for the view that was waiting for me when I stepped in. My partner and I kind of looked at each other, and we had that look that says things are going to go pretty horrible here. And we both almost immediately decided that this airway was going to be really difficult. And more than just really difficult, we needed to prep for a surgical airway, because there wasn't a way that I could see that we were going to get anything through just this gaping hole in his face. We immediately got on vital signs. At this point, the patient was still making meaningful movement. He was sort of rearranging an oxygen mask every now and then on his face. He was bleeding a lot and really gurgling through the volume of fluid in the back of his airway. We got some vital signs on, really just focused on getting a blood pressure on and a SATS probe. Internal CO2 was out of the question. There just wasn't any way to put it. And our first blood pressure was 60/40. His heart rate was in the 140s. He was working incredibly hard to breathe, and everything in his system was just working to try and keep him alive. Oh, his heart rate was 140 twice. And it was at this point that we sort of, we had to come to some quick decisions, and we had to figure out a plan for this patient's airway. And it was one of those cases where airway is the thing that comes first, but actually his massive hemorrhage was the thing that was going to kill him first. He was hypoxic, but still sort of present and able to help us and like move himself from the lower position to a more upward position. And he was, yes, he was hypoxic, but he was hypovolemic, and this was where our massive concerns really came in. So with that case in mind, I want to move through some of the things that sort of go through your mind when you're dealing with a patient like this. And not just a patient like this, but any patient in the trauma environment, where a lot of the time we feel like we're defined by the clinical skills that we do. And I hope that this is not something that is still as prevalent as it always has been. But the way that the system has been created is we are scope-driven practitioners. We sort of base our worth or our qualification or our level of provider based on what we can do for certain things in terms of skills. And we forget that often it's what's happening in the brain, in your brain, that you are working through to try and figure out how to make this patient the safest possible patient in your environment. That it's not really about the skills. And we can upgrade anyone's brains. And at the moment, there are some challenges around scope and providers, but anybody can change the way that they think about things and the way that they learn about things and the way that they expose themselves to things, even if we can't change scope at the moment. But one of the things that really does seem to define the advanced provider, and definitely sort of as the guidelines changed in 2018, was the concept of an advanced airway. And an advanced provider was really only as good as they were at advanced airway. And this is definitely not something that I subscribe to, but it's definitely something that kind of, I don't know, it's a prevailing thought in the system. What I want us to think about by the end of this case and sort of this presentation is that you are definitely not defined by your scope of practice, but rather by the decisions and the skills that allow the patient to get out exactly what they need. And if we keep that in mind, it's a whole lot better for the patient. What I also just really want to pay attention to is that pretty much never has a patient died because they didn't have plastic between their cords. Patients die from hypoxia, from bleeding out, from a whole range of other things, but not one of the causes of death ever is because they were not intubated. This case did challenge that concept a little bit, because if we couldn't manage this patient's airway, he was going to die because of bleeding out. And that is potentially as a result of the failure to gain an airway. Because in this case, the bleeding airway case, the bleeding and the airway are so closely entwined that the patient is at risk kind of from both. And in this situation, hypoxia was an overriding theme, less because of an airway and much more because of a hypovolemic state. And like we say, no one's ever died from a lack of plastic between the cords, except when that plastic between the cords allows you to treat the reason why that patient is dying in the first place. So I don't have permission from the family to share the image, so I have kind of just blotted it out. But what you can see here If you can imagine the gloves, sort of the blue hands around the top white part here is the patient's airway and face. His head was bandaged, and the entire airway, I mean, that dark spot in the middle is just the gaping hole where his face used to be. Too big for a BVM to fit over it, too big for an oxygen mask to properly cover the whole space, too full of blood to suction, sort of toilet bowl effect. No matter what you do, it just fills up. Even in the seated position, blood was just pouring out of this poor man's face. Teeth all over the place, and even bits of the hard palate sort of at the bottom of the jaw. Loose teeth up in the sinuses that you can kind of see just open into a wound of a face. I could almost even see the base of the skull, so sort of the area where his nose used to be, and the separation between where his brain should be and where his face was. And I couldn't in my mind sort of make sense of how this guy was making any kind of meaningful movement when I could physically see brain. It just didn't make sense to me. But you can kind of get an idea of the amount of blood loss. And this is an environment where we had already moved the patient twice. So he had lost a volume of blood on the scene where he initially had shot himself, and then a volume of blood in the ambulance. And then we moved him out of the ambulance to try and get some space so that we could access his airway. And even out here, he had lost again a massive volume of blood. Isolated head, massive bleeding. The things that we always go to for a patient like this were not going to work for this guy. There was literally no structure to his face to be able to apply a BVM mask. There was no hole to put an LMA in that I could see that we weren't going to potentially cause a whole lot of damage to his sort of cranial vault into his brain space. And the whole time we were initially assessing him and trying to figure out what the next step was, he was holding my arm or gripping my hand. He was meaningfully interacting with me in a way that meant we couldn't just leave him because he had some kind of engagement. And this was probably for me the most difficult thing is knowing that this patient has very little chance of survival, but right now he's alive, and right now he is engaging in a way that is very human and very easy to understand as somebody who potentially has a chance. Even though looking at his face, you know there is very, very little chance for his survival. Never mind the fact that his face didn't allow for a whole lot of stuff. His physiology didn't allow for a whole lot of stuff. And if you weren't paying attention, it might be very easy to just think, well, let's just sedate and intubate this patient so that we can get control of this horrific airway and bleeding, which was the set of thoughts that we went through. But there were all these barriers along the way to how do we do that safely? How do we not be the reason this patient dies, as opposed to his condition being the reason that he dies? And so what I really want to get to is this concept of managing the airway in context. And we always feel like, you know, if I just manage the airway, I'm going to sort out the problem and we're going to move on and things will be fine. But that's very, very rarely the case. In a theater environment where you have a patient who is stable and under control and probably pretty well pre-oxygenated and fasted and all the conditions are perfect, and it's a temperature controlled environment where you don't have golfers watching you, it's a whole different story to when you are in the real environment and things are now really challenging. So what we've done is we've created this checklist for safety, just around how do we create the safest possible option for our patient in this difficult airway environment. And it takes into account all of the things, and maybe there's some more that we could add to this, but all of the things that might kill the patient in the pursuit of airway. Simply jamming a tube down the throat is definitely not going to be the way that we win in most of our really sick patients. It's going to be the very last and the least exciting step of the entire airway approach. So we've put together this sort of checklist process around optimizing oxygenation, perfusion, ventilation, medications, the team, equipment, having a pause point just to think about, are we in a situation where the insertion of this airway is going to be the safest it possibly can be? Giving the medications, and then the least exciting stuff, which is really placing the ET tube. And if we think about this patient in front of us, all of the opportunities for optimizing were not really present. We couldn't pre-oxygenate. A nasal cannula on his face was just going to be lost and create sort of blood candy floss. A BVM was not an option. We couldn't find anywhere to get a seal, no structure to put it over. PEEP was not an option. PEEP directly to the brain is probably not the best idea. Head up was the only option that we had available to us. In terms of perfusion, we couldn't stop the bleed until we managed the airway. We considered and gave TXA relatively quickly for the patient and started a fluid bolus, but that was really just a hurricane against a fart, to be honest. There was no way that we were going to be able to stop this patient from bleeding while we were trying to get control of his airway. Adrenaline was an idea, but he had so much endogenous adrenaline already flying around his system that the adrenaline that we did actually end up putting up probably did very little for this poor patient. And then an adrenaline infusion was considered a little bit later. In terms of optimizing ventilation, this was just not even possible. He was breathing incredibly fast, but obviously with no place to get a good seal and no way to put an LMA in, this just wasn't really going to be a plan. Optimizing medications was also another challenge because no matter what medication you give to this patient in the situation that he was going to do badly. His blood pressure was horrible. His heart rate was horribly high. His SATs were already low. We were dealing with CO2 that was trapping in this patient. He was shocked. He was circling the drain. And we didn't want to be the reason why he got there faster. So the medications we opted for were ketamine, which felt like a good idea at the time. And I don't think that there was a better option for it. And rock was available and drawn up if we needed it. And we did use it eventually in the later parts of the airway management. Equipment was probably the only part that we could actually optimize. And so we got everything out and sort of managed an airway dump space where we would have access to all the bits and pieces we needed. Honestly, we didn't even pack out an LMA or a supraglottic device because there just was no space to put it that I didn't feel like we were going to destroy the brain. So we did pack up a surgical crack kit, and that was going to probably be a very quick plan B if plan A failed, which it obviously did. And plan A was going to be, let's have a look and see if we can see anything that looks like an airway from the top. And if that one attempt fails, we are going to go straight to surgical crack. We had a plan for who was going to do the crack. We had a plan for all the equipment. We already had SATs that were sitting in the poor patient's boots. Obviously, a perfusion issue also played a role. We didn't have a map that was higher than 60, and we did not have SATs that were higher than 94. And so we were in almost this concept of a crash airway. So that's just the concept of the things that we could go and have a look at. In terms of airway assessment, we should be assessing the airway to try and figure out, is this going to be a difficult airway? So we'll put it into the context of this patient. We didn't have any airway history, but I don't think that was going to play much of a role for us. His predisposing conditions were horrific. He was dying. In terms of appearance, you could not see an airway. There was horrible distortion, trauma. He was a little bit on the obese side, so probably a little chubbier than what would be ideal, but definitely that wasn't going to get in the way of his airway stuff, not as much as the rest of his life. He didn't have a mouth. His neck was intact. His neck was structurally intact and really easy to palpate landmarks, and that was one thing that was going for him. And for him, we had 0 safe apnea time. So that means when you give your drugs and you stop the patient from breathing, how much time do you have to place that airway before they become hypoxic? And we were dealing with a hypoxic patient already. We were in a situation that was an emergency, not in an ideal location, so outside of a facility with resources. Yes, probably the access to the best resources in terms of ventilation and equipment and airway management stuff, but on the side of a golf course with loads of onlookers and some traffic and all that kind of fun stuff. In terms of experience, I had a fair amount of experience in teaching the approaches to airway and really playing around with lots of practice around surgical crack practice in pork models and on 3D printed tracheas. But this was going to be my very first surgical airway if it happened. And so that was playing quite heavily in my mind as well. It was early in the morning. I wasn't fatigued. I wasn't otherwise stressed, except for all the stresses that are engaged with an emergency call. So if we have a look at this airway assessment approach, we were really dealing with 3 possible positives for this patient, and all the rest were looking pretty grim. In terms of how things were going to go, we didn't have much data, and obviously in the emergency spaces we hardly have a lot of data. So previous airway attempts or problems, we had no idea. Previous views gained on laryngoscopy, it didn't look like we were going to be able to get any views, and there were no techniques or tricks that we knew that had worked in the past for this patient, because this was a whole completely different story. But in an ED setting, and definitely in sort of a theater setting, this information is really useful and really helpful. In the places where we tend to practice, this information isn't usually available. But if you have this information, this can be really helpful to inform how you're going to manage that patient's airway. And even if it's not from the very far away past, even if it's from a very recent past, so the last person to intubate had attempted, what did they see? How did they gain access to see what they saw? And what was the reason that they failed? That data can inform the very next attempt and make it much safer for the patient in front of us. There's a whole lot of stuff that helps us to determine whether something is going to be anatomically difficult, and we can use Boots and Moans and Lemon Short, and that's going to give us all the information around BVM ventilation, normal airway management in terms of advanced airway management, the application of LMAs or supraglottic devices, as well as the surgical airway stuff. But honestly, in the emergency spaces, you don't need to spend very much time looking at these things, because what we do know is even if the patient looks like, according to all of these algorithms and mnemonics, if they look like they're going to have an easy airway, the chance is really good they're not, because you're in an environment that is uncontrolled with a patient who is unknown. And so instead of setting up for the anatomically difficult airway only when we see it or when we think we're going to see it, what we should be doing is just setting up for the anatomically difficult airway in every single patient that you ever see. And that's whether you're going to do a BVM ventilation or an LMA insertion or a surgical crack or a needle crack or an advanced airway via the nose or mouth. If you are set up for the worst possible thing, you are much more likely to be able to manage it, even if it's not there. The second thing that's really important, so apart from the anatomical things that are important, is going to be the physiological things that are important. And that's going to be things like functional residual capacity. So the patient who is pregnant or pediatric or bleeding out or septic, those patients are not going to be able to tolerate very long periods of apnea. Putting them head up can assist with a functional residual capacity and better ventilation. Putting them head up can also assist with reducing the risk of aspiration and making sure that the patient has the best possible view for the intubation. Other physiology things that are really important we'll get into a second, but there are also really important team dynamic points of view and how you've set up your environment. How easy is it to access your equipment? Have you pre-oxygenated? Have you ventilated this patient in an appropriate way? And there are three main things that really kill the patient, especially in extremis in our environments around the airway: hemodynamics, hypoxia, and acidosis. And if we put this patient into context, he was hypotensive without the ability to stop the bleed. He was hypoxic without the ability to pre-oxygenate. And he had a severe metabolic acidosis without a blood gas. We could tell you this simply because he had lost so much volume and simply because of the underlying condition that he had. And so we were kind of fighting against all three. And there are some tricks and tools that we can use to try and mitigate these risks, but there is going to come a point where nothing you do is going to change those risks. But we need to be aware of them, because if we're aware of them and we can do something to try and optimize the patient, things go a whole lot better. We need to think about the patient who is clinging onto oxygenation, just like this. And if you have a look, you can almost see the oxyhemoglobin dissociation curve over here. If this guy was hanging up onto the roof and just kind of looking over the edge, we would be sitting in the SATS range of like the 94s to 100s. Loads of time, very little pressure, patient under control, pre-oxygenation achieved. As soon as we sort of start heading down the oxyhemoglobin dissociation curve to SATs of less than 94%, things change relatively fast. And if you can imagine a patient hanging on at around 90%, the difference between 90 and 60 is seconds, whereas the difference between 100 and 98 could be minutes. And so this patient obviously was this guy. He was hanging on to the edge of that cliff, and anything and everything that we were going to do for him was potentially going to push him over the edge of that cliff, especially considering that we couldn't pre-oxygenate, couldn't ventilate this patient. And there's just your oxyhemoglobin dissociation curve. So what did we do? We put him head up. Head up was the only way that he could really tolerate sitting anyway. He was very uncomfortable, obviously, sort of 30-degree head up. He needed to be 60 or 90-degree head up, leaning slightly forward and allowing the blood to drip out. That makes it quite difficult from an airway management point of view, and is why we ended up putting the patient out of the ambulance and onto the ground, so that that first look could be the best possible look that we could get from behind the patient, to try and optimize height challenges and space challenges outside of the ambulance. Pre-oxygenation would be great. It's not something that we could do for this patient, but the options are things like a nasal cannula at relatively high concentrations and high flow rates, so 15 liters per minute, in the patient who is relatively sedated. And that pre-oxygenation, or that apneic oxygenation, should stay on throughout the airway attempt. Not an option for this patient. He didn't have a nose, and the hole where the air was coming out was not easily discernible from our perspective. PEEP is a really nice way to pre-oxygenate a patient, especially if we're going to add PEEP and positive pressure ventilation. Obviously, a seal around the face is quite important for that. And then the head-up position also helps a little bit with that pre-oxygenation. This is just the idea of that apneic oxygenation, not an opportunity for this patient. You have to think about shunt and perfusion. So we have to think about not just delivering oxygen to the lung surface, but how do we get that oxygen from the lung surface out to the cells that really need it, the brain, the heart, the lungs. Because just delivering oxygen to the alveolar surface on its own is not enough. Just delivering concentration is not enough. How do we get that oxygen to where it's needed to actually prevent hypoxia? And that was a really big problem with this patient. We had very horrible perfusion, which immediately created a shunt. So we had surprisingly better ventilation than we did perfusion in his lung surface, even though his ventilation was also horrific. But that's going to lead to hypoxia systemically, but also a rise in acidosis systemically as the CO2 just gets trapped in the system. And so where we can, the addition of positive pressure ventilation and the addition of PEEP really does help to optimize and reduce the shunt sometimes. And sometimes it's about optimizing perfusion on the other side. So increasing the blood pressure, increasing the perfusion state, getting some inotropes on board, stopping the bleed, maybe filling up the space with blood and blood products. And that might get us to a better situation. And that is not something that takes 2 minutes. Resuscitation before the airway management may be the thing that keeps the patient alive through the airway management. So how do we do that? We try and stop the bleeds. We consider TXA. We think about pain management options. And this seems counterintuitive just from a blood pressure point of view. But if the patient needs less oxygen, if their demand is lower, then what we can deliver will be matching what they need. And so we may not need to then deliver as much oxygen as we were, and we may not need to ventilate as much as we were in order to get rid of all that CO2. Dirty adrenaline is an option. We'll chat about what that looks like in a second. Or an infusion. Have you got time to go and set up a properly calculated infusion? But what if I can't stop the bleed? What if stopping the bleed is going to be as a result of being able to pack the airway, which is going to be as a result of being able to manage the airway, which is going to need some perfusion to allow for that to happen? And you kind of get caught in this barriers to airway management, but also to perfusion management, but also to the shock management. And it makes life really difficult. We can, at this point, for most patients, go and have a look at the shock index. And this is just how shock index can be adapted to your advanced airway approach, specifically the RSI approach, in that a shock index is your heart rate divided by your systolic blood pressure. It's not 100% accurate, but it really does give you a good idea of how much trouble your patient's in, and are you ready to throw some drugs into the mix on top of their condition. So a normal shock index, think about a normal patient, a heart rate of around 70 and a blood pressure with a MAP of around 90. That would be a shock index of around 0.6, maybe 0.7, and that's pretty normal. As soon as we end up in the situation where your heart rate is higher than your systolic blood pressure, for whatever reason, the risk of medications really goes up. And so any of the medications we give, regardless of whether they're cardio safe or hemodynamically safe, all of them in the patient who is under resuscitated are going to drop the patient's blood pressure. So there are two sort of definers here. If you've got a patient who has a shock index of over 1, there's a really good chance, and I can almost guarantee that your patient is going to arrest if we throw a ketamine or an etomidate into that patient, never mind the paralytics that go with it, at the doses for airway management. Your shock index more than 1 also increases, obviously, the lactate sort of component as the patient is using more oxygen and glucose, and anabolic respiration is, sorry, not anabolic, anaerobic respiration is kind of happening, and increases your 28-day mortality. But the thing that's really interesting here is that if you have a patient who has a shock index of more than 0.8, you are almost predicting the outcome of resuscitation. So you need to work a little harder pre-intubation so that your post-intubation period is a whole lot safer. And we all think about this as the ALS responsibility or the doctor's responsibility, but actually it's the entire airway team. All of us are responsible to make sure that the patient in front of us is in the best, safest situation for airway management. And if that means getting a fluid bolus on board and at least priming whoever's coming to help you that they're going to need to bring adrenaline or at least start something, that might be the way that we end up doing that. What we ended up doing for our patient, because I didn't feel like we had a lot of time and I didn't have a lot of bandwidth to kind of figure out an appropriate adrenaline infusion, and the patient needed fluid, was we just put one amp of adrenaline straight into a liter of saline. We actually used ringers because that's what we had available to us, and we just ran it. And we ran that for this 90-odd kilogram patient to achieve some adrenaline, some support to keep him alive through our airway attempt, and some volume. And I think that is potentially why the patient made it through the airway management period, and then later some other stuff happened. We then need to think about not just the anatomical difficulties and the physiological difficulties, but the things that make airway difficult for you as the practitioner. And so it's this concept of the psychologically difficult airway. And I alluded to it earlier when I stepped into the ambulance to treat this patient. My very first thought was, this is not going to go well. And immediately you stepped into a psychologically difficult airway. As soon as you see something that gives you a tachy, that makes you anxious, that makes you think, I don't know if this is going to work out, immediately you're in your own head. And all of us do that. We are human. But what we need to be able to do is talk ourselves back out. We need to be able to say to ourselves, I have the equipment, I have the knowledge, I have the skills, and we are going to make this work, whether it's via the nose or the mouth or the neck. This patient needs to be managed in terms of airway and needs to be managed in terms of bleeding. So just some really interesting data. At your normal heart rate, things are good. As soon as your heart rate goes up to around 90 beats per minute, your fine motor skills reduce. So that makes you a little bit less smart. By the time you get up to like the 120s, especially under pressure, your complex motor skills deteriorate. So that's like the things where your brain and your hands have to really be connected. By the time we hit a heart rate of 150, you've lost peripheral vision. You become completely tunnel visioned. You lose the ability to think broadly. So what happens is you can often see the problem and act on it immediately because of adrenaline. But what you can't see is alternatives. And what you can't see is, how do I work my way out of this situation that I maybe have gotten myself into? And you also get this concept of auditory exclusion. So auditory exclusion is where you can't hear what basic things that you're supposed to be able to hear. So things like the alarm on your monitor start to disappear. Small unassertive comments in the team are things that you're not going to be able to hear. And so people are going to have to be really clear with you and really obvious with you in order for you to be able to hear what you need to hear. So just from the perspective of looking down the airway, all you can see, all you can hear is what's that sound rushing in your ears, and you need to now get this airway sorted. You can't hear that the SATs are 42%. And once your heart rate goes to 175, and I'm really glad that this doesn't always happen, but you are in a fight or flight option. You're freezing, you're having irrational thoughts, you're anxious, you often have submissive behaviors, And then the very worst thing that could possibly happen is a loss of bowel or bladder function, which I'm very glad doesn't really happen too often to us as practitioners. But we all talk about needing to have that extra pair of underwear for these really stressful situations. And why I'm showing you this is because this is not unique to us. This is a human thing. And you cannot expect that your brain is going to be able to do what your brain needs to do, because it is human, when it is under massive amounts of pressure and where you are in a physiologically stressed state yourself. You are just, it's unreasonable to think that you're not going to make mistakes, that you're not going to mess things up, that you're not going to get tunnel vision. And that's just a reminder of this patient's airway. He was a anatomically difficult airway, a physiologically really difficult airway, and definitely a psychologically difficult airway. He was the trifecta, all three. And this is where that human factor really lines up, where you get this lining up of the Swiss cheese for things to go wrong. Mostly, we are eluded by the fact that things are going to be easy. So this is the thing that we actually mess up the most. We're impatient to get things done faster. So instead of waiting that extra 5 minutes to pre-oxygenate and resuscitate the patient pre-intubation, we rush to the intubation because we just want to get the tube sorted, even if it's at the cost of the life. And the very last and the least likely reason why things go wrong in our environments is incompetence. And why I say it's the least likely thing is because every single human being in your environment has a qualification. They've been passed on clinical skills, thought process, theory knowledge. They have shown competence in some way. The problem is not competence, but competence under pressure and competence in a high stress, high physiological demand environment. That's where sort of humans fall apart. Cognitive load is overwhelming. All the things you have to think about to be able to get an airway sorted out in a really sick patient suddenly become just bigger than what you can deal with. And so what we should be doing is we should be offloading to checklists. We should be offloading to tools that can help us make better decisions and that can help us catch the holes in our thought process and create that sieve of safety for the patient in front of us. If we are too arrogant or doff to use checklists and tools, cognitive offloading tools, then should we really be managing airways at all? It's a question that we probably do need to think about. And it's not just around airways, it's around a lot of the high acuity things that we do in our environments. So this is an example of an equipment checklist. We've already had an example of a thought process checklist where we had a look through optimizing oxygenation, perfusion, ventilation, medications. This is another example of a checklist. So it is an equipment checklist, but it's also a safety checklist so that you are always set up for the worst and the best possible environment. So what are we doing for pre-oxygenation? What are we doing as plan A? What are we doing for plan B? And what are we doing for plan C? And then probably the thing that we suck the most at is sharing the plan. So often we'll think, well, this is obvious, but I can almost guarantee that your team are going to let you down if you don't tell them what's in your head. If you can't articulate the thought that's in your head and you can't share the plan with them, when it comes time to execute the plan, the chance is very good that they are going to fail at that plan because you just haven't shared what's happening in your head. We need that shared mental model and we need to have that understanding with each other. So this is the plan that I like to use. It's a kind of a checklist. We are going to try something. So in this case, face mask ventilation. If that doesn't get us where we're looking, we're going to try supraglottic device. If that doesn't get us to where we want to be, we're going to try endotracheal tube. And if that doesn't get us to where we want to be, we have the option of a crack or a surgical crack rescue. And those are plans we need to be sharing with our team. And we have to be making the idea that a surgical crack is an overt plan. It's not a failure. It is part of the airway plan. And if we can't win with the other options, we are going to win with a surgical crack. Because a win for airway is oxygenation and ventilation. It's not a tube in the mouth or a tube in the nose or a tube in the neck. It is the avoidance of hypoxia and the improvement of oxygenation. So what we really need to do is we need to plan for the worst and hope for the best. And so we have to have all of these things out, ready and available. And what the patient that we were dealing with in this situation was looking like the impossible airway. It was a patient who we couldn't bag mask ventilate, a patient I didn't think I was going to be able to intubate, and a patient who I didn't think a supraglottic device was going to add any value and potentially was going to cause harm. And so what does that mean? It means you have to be ready for the crack. That means every single time we set up an airway station, we're getting ready to intubate a patient, you're thinking about picking up a laryngoscope, we have to have the crack stuff out and ready. There are three sort of stages of readiness for a crack. There is the ready state, which is kind of a relaxed state, this green state. And that is that we have it out. We discuss the idea of a crack. We can see the kit. We know what's in it. And we know that if we need it, it's there and it's available. That should be for every single patient we ever do any kind of advanced airway maneuvers on. The second state of readiness is the set, and that is where you are one step closer to being ready for the surgical crack. So before any of the drugs go in and before we're ready to try and intubate the patient, we've marked the surgical airway landmark, we've palpated it, we've made sure that we're really comfortable with where it is. The kit is at the bedside, the kit is open. There might even be a scalpel in your hand or your partner's hand, whoever's ready to do the crack. If it's an ILS crew, then you might have a needle out and ready with hands on the landmark already. And that's going to be for the patient who you anticipate a relatively difficult airway, but there is still the opportunity that the other options might work out. And then you've got the red, the about to go. And this is kind of how we set up for our patient. We quickly got out things we thought we might need for the tube, and we prepared a second setup, so a double setup station for the crack. That was really easy because we use a setup crack kit. So all we had to do was open the kit and everything was already there for us. And this is essentially the double setup means you've got one practitioner on upper airway and you've got one practitioner on surgical crack. If the laryngoscope leaves the upper airway without a tube staying behind, the decision's already made. We are going to cut, and that cut is essentially already ready to be done. So if you're about to go, you've potentially already prepped the landmark, you've maybe opened the set, you've got the scalpel in your hand, you've maybe even cut through the skin already, and your last move as that laryngoscope comes out is literally to pierce the membrane and put in an airway. And that's where we were for this patient. We had a really quick chat between the two of us. We said, we're going to try an upper airway approach, see if we can get the laryngoscope blade somewhere that might show us something useful. If we can't get that right, blade comes out of the mouth, blade goes into the neck. Those are the two steps. And that is essentially what we ended up doing for this patient. We ended up giving him some ketamine, a very low dose of ketamine just based on his hemodynamics. My partner had the laryngoscope blade, tried to get it somewhere into the mouth to have a look, made the decision that he was going to be causing more damage to the patient's brain and base of skull. And as soon as he pulled out the blade, we were ready to cut. I had fingers on landmark and managed to do the surgical crack relatively quickly from the administration of the ketamine. The decision to make, or the difficulty in the crack is really the decision to do the crack. And so just based from this single experience, it wasn't difficult to do the surgical skill because I think it's something that we practice and we think about relatively often. The difficulty was, and the barrier was, okay, it's time to move to the crack. And then we were very lucky in that in this case, we'd had that discussion en route. We were primed for it. We were ready for it. We had some information and the decision was not that difficult to make. But I don't want you to leave this presentation today without this thought in your head. If you leave the decision of the surgical crack to that high risk, high stress, high anxiety situation where your heart rate's 178 and you're just holding onto your bowels, you will not make the decision to crack that patient. You need to make a decision now, today. What are the circumstances in which a crack is going to happen? And if you can make that decision now, it's way easier to put it into play in front of the patient. And so the decision should be made around an inability to confirm alveolar ventilation or delivery of gas to the alveoli. If you can't get the chest to rise, if you can't get a CO2 reading, and you can't get access to that airway with any other option, you are in for a crack. If you pick up the laryngoscope, you are in for a crack. There are some checklists, and this is another example of a checklist that you can use. This is a read-do checklist. So this is where you have somebody reading it to you as you obviously feel quite anxious. It's a way of making sure that you're not missing any steps and that you have the best possible chance to get the surgical airway sorted out. And this is just one example. What's more important than a checklist for this kind of interaction is practicing the checklist. And what's more important than practicing is perfect practice. We have to be thinking these thoughts. We have to be thinking through our thought process. We need to be putting our hands where they need to be with the right equipment, and we need to practice the mind-hand communication to be able to get these skills done really well. And if we practice, it doesn't really matter what kind of approach you use, whether you do the scalpel finger bougie technique, whether you use scissors, whether you use a tracheal hook, it doesn't matter. What matters is that you know what you're going to do at the time and you have the equipment to do it. So super quick summary. We are not defined by our airway skills. Rather, we are defined by our ability to improve oxygenation and maintain oxygenation for the patient. When we think about airway, we should be thinking about optimizing everything we possibly can prior to the airway management. We should be thinking about optimizing environments, the team, sharing the plan, using cognitive offloading tools to free up bandwidth, calling for help, planning for the best, preparing for the worst possible outcome. And that's pretty much all I wanted to share today. What I do want to do is just open up to anybody who has any thoughts. Maybe if you've had to complete a surgical crack before, if you've had to move to that difficult part of the airway, I do just want to open up mics. Sorry, I'm being really slow today, but I can't find the right screen to open up the mics. Okay, so I see there are some comments in the chat. Let's maybe deal with those while I deal with my technology challenges. So the first one is opinion on giving a patient any drug that would compromise an already compensating patient. I'm not sure who asked that. I don't know if you want to maybe ask it in words so that I can understand the question better.
It's Danielle Brown.
Danielle? Okay, we'll come back to Danielle. I see UD's hand is up.
Hi, Caleb. Can you hear me?
Indeed.
Hi. Firstly, thank you very much. Outstanding presentation, a really complicated case, and well done to you and the team. Really well done. I wanted to ask a question that I hope is not taken badly, and I hope it doesn't reflect a perhaps a poor attitude. But I'm considering the patient like this. Did you to be successful with your airway management? Or was there a factor at any point to go that you should just consider leaving this patient to be making him comfortable, and I suppose more of a, may I say the word, palliative or an end of life decision that you kind of changed towards?
That's such a good question, and it's actually something that we reflected on a lot after the case. There were a few factors involved in why we went all out for this patient in the first sort of part, and the first one was the crew who were with the patient and the patient's initial presentation to us, despite his horrible vitals, was, and I said this a few times in the presentation, he was making meaningful engagement. He was nodding his head when he was answering yes. And he was like gripping my arm when I was trying to assess him. And that, like, as it probably wasn't the best decision, knowing clinically that he was, I mean, his brain was exposed, but it was so difficult not to do the thing for him that we sort of by default made the decision that we were going to go all the way. He wasn't going to die from hypoxia. If he was going to die, it was going to be because of his injuries that he had sustained. And that, it's so weird because we didn't have that conversation. But when we debriefed about it afterwards, that was the conversation that was kind of had. It was like we were already in, and we had made the decision to be in. And I think if we'd been able to pull back, we would have been able to see it maybe from a much bigger picture. But I'm not sad that we didn't let him die from hypoxia. I don't know if that answers your question.
Thank you very much.
The next hand up is Tom.
Yeah, morning, everybody. I hope you're all well. Thanks. Great case, difficult case. And all the points you brought up are very, very relative. I've had probably 3 similar cases in my career. And the one thing that comes to mind, because I've had this myself, is while the patient is sitting up, leaning forward, keeping the airway open, understandably, as soon as you lie them down, you're going to lose that airway very quickly. What was your flying time to the facility? And knowingly, you know that when you make that decision to crike, if you don't get that crike, it's even more of a situation where it becomes even more stressful. I think your heart rate is going to be in the 200s. Or because of the helicopter, did you decide we've got to crike this guy if we're going to fly him, because otherwise we cannot have him sitting up in an aircraft on the way to the hospital? What's your thoughts on that one?
Yeah, for this guy, it was more around we have to manage the airway in order to stop the bleed. And that was whether the right thought or not, that was kind of the train that we were on. Is like, if we don't do anything about the airway, we can sit him up. I mean, we could fly him seated, that would be fine. But he was going to continue to pour blood out of this hole in his face. And that was, in both of our minds, kind of killing him faster, if that makes sense. So it may have been that sort of bias of we're on the bandwagon now, we have to get this airway sorted to get his bleeding sorted. What did end up happening with this poor guy was probably around 6 minutes after the crike, we had positive vent tidal CO2, and we had a really good chest rise, and the crike had worked really nicely. We were getting ready to package and get him into the machine, and he lost pulses, I think more from a hypovolemic shock state than from anything else. So the thing that we were trying to manage the airway for in order to keep him alive is the thing that ended up killing him.
Yeah, and I was going to ask on that, once you got the crike in, did you actively pack that airway around in the mouth, etc., to try and tamponade any bleeding that was happening?
Yes, we did. So almost as soon as I started cutting, my partner started packing the airway, because he was pouring, like he was literally pouring out so much blood. And like as it was happening, we were looking at each other thinking like, this is not survivable. But we're in it, like we're in it now. We're elbows deep in. We're gonna give it the best that we have.
Yeah, no, I hear you. Listen, great job all round. You can only do what you can do, but great presentation. Thank you.
Thanks, Tom. Next is Mandisa. Mandisa? Okay, I'm going to go to Tulani and then we'll come back to Mandisa.
Hi, everyone. Hi, Kelly. Thanks for the great presentation. I think as you were busy with the presentation, I'm starting to tick all the boxes that generally on how we should be practicing. I'm not going to say much about that, but what I do like, some of the stuff that you mentioned is that airway management shouldn't just be an ALS or ECP scope, is that everybody that is within that patient should be involved and knowing what to do, so that there can also be safety measures in terms of, let's say, the patient's blood pressure is dropping or the shock index is high, and the ECP is not able to notice that. So everybody should be knowledgeable about that. What I do want to ask you is that, I don't know if you mentioned it, I didn't hear it, but the prognosis of the patient. And then secondly, with regards to the RSI medication. I know RSI gets practiced differently across the world. I know for a fact that where I'm currently it's usually fentanyl, ketamine, and rocuronium, whereas in such cases that you presented would leave out the fentanyl completely and mostly give ketamine, but at a half dose, whereas rocuronium, you still give a standard dose of the patient. What are your thoughts on that? And how much ketamine, did you also have the dose of ketamine? And lastly, once the the airway was secured, the adrenaline infusion, did you manage to put a more of a structured adrenaline infusion that was run on a infusion pump or on a syringe driver?
Yeah, so this the standard approach to RSI is something that I often kick against. Like for me, anything that is a blanket answer is probably wrong at least 40% of the time. So is there a standard way that is always safe? No, there's a patient in front of you. So I do like the idea of using fentanyl for a patient myself, especially if the patient has sort of a raised intracranial pressure or we're dealing with the patient who is in a lot of pain prior to the intubation. But I didn't honestly even think about it for this patient. It was I need to get control and sedation and pain management one time. So I decided what's going to be the quickest, and that was going to be ketamine. We did give the ketamine in such a way that we worked out a dose, but I didn't give a specific dose. What we ended up doing was giving ketamine super slowly so probably over the period of about 30 seconds until the effect I was looking for was achieved. And so it actually ended up being around a third of the dose that we would normally use for the hypotensive patient. So he was around 90 kilograms. Should have gone at a 1 milligram per kilogram for him, which is what we drew up, but ended up only giving him about 30 milligrams. And that was enough to drop his level of consciousness to the point of we could manage everything that we needed to manage for him because he was so hypotensive. And then, yes, we did manage to formalize to an adrenaline infusion in the sort of 2-3 minutes post the surgical crack once it was secured and just before the cardiac arrest that we then noticed. I see, Mandisa, your hand is still up. Are you able to unmute? Okay, we're going to go to Lucas. Oh, sorry.
Hi, Caleb.
Sorry, Lucas. Sean is in front of you. Sorry, I just
No
can't
worries.
read. Sorry, Sean.
Hi, Caleb. Thanks again. What an awesome presentation as always. Just something that Professor Jacques Wilson taught me around exactly something similar to this is to, if you're able to, is to attempt to try and build a structure. So pack it as best you can and then try and attempt to bag valve mask the patient if you're able to. So either using a compressed gauze and or a hemostatic to try and absorb as much as you can to allow you the ability to try and visualize the airway before a surgical process. But again, if that's the last resort, he said, then go ahead. Your cricothyrotomy is the best option. But I don't know if you had that ability or attempted to try and hemostatically build a structure in and around where you were to try and see that airway.
Yeah, I mean, maybe, but I just thinking back now, I don't know. He didn't even have lips. He didn't have any way to sort of pack the gauze that would allow for a seal. So I don't think it would have worked. But it might have been worth a try. I don't know.
100%. But well done to you and the team. I think you guys did an excellent job. Just
Thanks,
the thought process around the hemostatics.
Yeah, and I think when you've got the sort of the facial structure still a bit intact, it is definitely just like your Lafort 3 fractures.
Yeah.
For those patients, yeah, if you can sort of pack under the lips and into the oral cavity to try and create that gap, that's super
correct.
Yeah.
100%. Well done.
Nice. Thanks, Sean. Lucas.
Hi, Caleb. Yeah, also just want to say well done on a difficult case. And then I wanted to ask, if I understand correctly, you guys first attempted laryngoscopy, is that correct?
We did a very, very short attempt. So my partner had the laryngoscope out, tried to find a space to put it in where he might be able to see, and then we quickly called it.
Okay, so just a thought, just based on what I would do, obviously I wasn't there, but in someone who's almost on that borderline of hypoxia where seconds really, as you said, is everything, you're almost confident that laryngoscopy is not going to work. Is there maybe benefit to going straight for the cric just so that you can minimize time under sedation where you're not getting oxygenation? It's something I would probably consider in a case like this. I just wanted to know your thoughts.
Sure. I think that's a really good question. In my mind, the tick box of I can't intubate has to be ticked. And it's not hard and fast. So I guess if you really think you can't, then there's nothing wrong with going straight for a crack, 100%. But for me, it's the can't intubate, can't oxygenate, and that might just be a bias on my side, and maybe it took extra time simply because I wanted to tick that box. I don't know if that makes sense.
It does, yeah. Thanks, Kevin.
Moira.
Good morning, team. Good morning. Good morning. You're actually giving me goosebumps, eh? And you're giving me flashbacks from some of my cases. The most recent case I had was a gunshot face. However, I still did have structure. I had a, but it was a transfer though. But that guy's HB was dropping from 11 to 8.
Yeah.
That's the way that guy was losing blood. Even though it might sound simple, but it actually worked. We had the balloons. It was left cheek, transverse through the mouth, out by the zone 2. Ne? So we don't know. We had to take him for the scan. So we couldn't really say what was going in there. But he had an expanding hematoma. And he was like really, really, really not just oozing blood. He was losing blood. What I did was we had the balloons inflated it. However, the one came out. But what I also did was packed. I also assisted to break a few amps of adrenaline. Because he already had his TXA. He had it all fruity tooty. You just name it. And what we did on the one side of his mouth, we had the suction catheter in, filling up with blood as well. Then I also assisted to break a few amps of adrenaline, goes in there, put it in his nose, suction, put it in his nose, in the mouth, we had it packed. At least my patient had structure, facial structure. Yours didn't. But I take my hat off to not racing just for, blindsided or one-sided or single-sided, whichever you want to say. I really loved your presentation, the way you ticked off all the boxes. I take my hat off for you. Honestly, I loved your presentation.
Thanks, Mario. Thanks for sharing your case as well. I think there's no one case that's the same, right? So every case is going to have its little nuances that we can work around to make things a bit better. And we're going to mess up stuff on our cases all the time.
I'm telling you. There's just another thing. I just love the way you opened your presentation. It's not about your skill. It's the outcome of your patient.
Nice.
It doesn't matter. Whether you be you just name it, even a sweeper. If you have got some skill, it's your skill that's going to save your patient's life. And I thank the floor.
Thank you so much, Moira. Mandisa, I'm going to give you another chance if you are able to unmute. I see your hand is still up. Sandile.
Morning, everyone. Am I audible?
Yes, you are.
Thank you. Excellent presentations, and I was touched more by the decisions that you use. They are very much excellent, and they are current to what is really happening to us. Especially the one that you use with pulse rates that you actually use to calm yourself down even before you get to the case. I remember that as a student not so long ago. Fortunately for me, I had a mentor who was able to guide me through. Now, I may have had experience as ILS of quite a few years before I took on my ANT studies. However, whenever you are faced with a situation where you have to stick a needle to someone's body to actually help them to breathe, it really plays with your mind, even though you've been practicing. But the important thing now is that it's not a mannequin now, it's a real person. And that tool that you use to calm yourself down before you even get to the patient is really good, and very well done on your case, and thank you so much.
Thanks, Andile, and thank you for sharing your reflections. I think you hit on all the things that people are really stressed about. Moira, I see your hand is up again. Is it up again or still up? I think it's still up. Cool. Then the link for the CPD will be shared just shortly. Arthur, yes, TXA was administered. And then the word of the day is going to be Kaiko. Before we jump off, Lydia, I see your hand is up.
Hi, Caleb. Yeah, you asked me beforehand for some insight into a case that I did. I don't actually know what little old me here on the farm can contribute to such a large platform. But my case was pretty much let's say a shit show. The intubation initial attempt had a great view, everything went well, but I think what opened my mind the most to the potential of a crike for this specific case was I actually did a consultation, and never ever have they asked me, but this day they asked me, are you prepared to crike this patient? And I recall feeling the membrane while I'm on the phone on the one side. I'm like, oh no, I'm cool, but I don't think it will be necessary. And I did the airway course literally 2 weeks prior. And I was in the airway, ready to tube, had a beautiful view, and this guy just desaturated, his sats literally dropped like a stone. And the whole vortex approach just came into my mind, and I went and I flipped through all my methods just to get this guy oxygenated, and ultimately ended up taking the blade. And that part was not difficult. There's muscle memory, there's practice, that's not difficult. We maybe do not anticipate how tough the membrane might be. And that was a whole different spiral for me. But ultimately, it's the decision making and knowing I need to do something else. I need to change. I need to move over. So yeah, thank you. Thank you for always imparting in us. Because I think if it wasn't for the airway course and your inspiration, I probably wouldn't have been as confident.
Yeah, and I think it's really important it's not about where you do an airway course, it's not about what airway course you do, it's about letting your brain go to those thoughts that you don't want to think about. Thinking about when am I going to do a crack? Thinking about when am I going to do a thoracotomy? When am I going to do a finger thoracostomy? When am I going to do the resuscitative hysterotomy? You have to think about those things now. You can't wait until things are bad. Tom?
Yeah, you know, when you listen, just more things come to mind. So just another thing to remember is that shock index, not so much just in this case, but every case. And I couldn't agree with you more. That shock index is critical, and we have to resuscitate first before going down the road of the drugs. If you miss that, your patient's going to crash, if not die. And it's really critical to be on top of that all the time.
Yeah, I think especially in the early days of RSI, that is what killed a lot of patients. And we all sort of would throw the drugs in and then look at each other and go, oh, he was really sick. But he wasn't that sick. We didn't help him get better before we made him more sick.
Absolutely. And you know, the rock, for example, as you know, you give that rock in a patient who's hypotensive, you take away the only mechanism they've got to keep the pressures going, and it makes it even worse. So, and you know, sometimes, like you did quite rightly, give a lower dose of ketamine in the hypotensive, high index patient. Absolutely. So yeah, kudos.
Thank you, everyone, for your participation this week. I think it was a really engaged presentation. Thank you for joining, and thank you for doing things the Coffee and Cases way. We will see you guys next week.